second most important case in skin malignancies, that is squamous cell carcinoma. This is a very fairly common case that can come in the examination, and it is the second most important skin cancer most commonly occurring after a basal cell carcinoma. The agenda of this discussion is to give you a sample case snippet as usual, little bit on the management perspectives, recent advances, a little bit on the lymphatic dissection methods and reconstructions, and we can take the discussion forward, shall we? Okay, so the examiner asks us to present the case. Okay, like in various examinations, sometimes you might be asked to write down the history, sometimes not. It varies from center to center. So this case is a 65-year-old homemaker, para 2, a postmenopausal female with hypertension, which was controlled with oral medications, presented with an ulceroproliferative lesion of 4 into 2.5 centimeters in the medial or the inner aspect of the left knee for 8 months. Note that the patient has a history of flame burn over the leg 20 years back, which required skin grafting. Okay, this gives us a clue to something sinister that had happened in the past. So the past history of an exposure due to flame burn is something very significant. Okay, then let's come to examination. On local examination, the skin of the region appears to be reddish. It has a reddish lesion which is cauliflower like appearance with everted edges with copious discharge coming from the lesion while we are trying to palpate the lesion. The surrounding margins are well defined, and there is a zone of induration along the ulcer which bleeds on touch. The ulcer is fixed to the skin and subcutaneous tissues over the previously grafted skin, but the bone and the underlying muscles appear to be free. Okay, this is also something very important because it gives us the depth of the tumor as to how much we need to excise the tumor when we are planning surgery. There are no palpable inguinal lymph nodes. This again tells us how much nodal resection or nodal management we need to do. The chest and abdomen appears to be normal, and the opposite limb appears to be normal because this is confined in one limb, so it's always prudent to take the history of the opposite limb as well. Okay, so look at this ulcer. Look at this ulcer. See, it is cauliflower in shape. If you like having cauliflowers, it looks like the floret of a cauliflower. It is reddish, and see, all around this there is this red area of induration. There's a little bit of contracture, if I might say. There's a little bit of contracture of this skin grafted area before, and this entire burn skin appears to be contracted. Of course, if something heals by secondary intention, the granulation tissue forms and the bed contracts due to presence of myofibroblast and later on matures into fibroblast, and this collagen remodeling happens, because of which the tissue starts to contract or shrink. Okay, so this appears to be like a squamous cell carcinoma. Okay, so now the examiner asks us about the diagnosis. Okay, so diagnosis in a MS or a DNB examination, we should be very particular about the ways that we present our diagnosis. So we'll say that this is a case of a 65-year-old female patient with an ulceroproliferative lesion over the left knee, probably of malignant etiology. Due to the history of a previous flame burn, it is probably a Marjolins ulcer. Okay, the clinical stage is T3, N0 and MX, of course, because the size is an important prognostic factor. We have no lymph nodes, and of course we've not evaluated for metastatic workup in this patient as of now. Okay, so the examination asks us now, since we've given him a hint that it's a Marjolin ulcer, they ask us what is a Marjolin's ulcer. Okay, so Marjolin ulcer is an ulcer that appears due to chronic inflammation, maybe from a burn, maybe from an old scar, or maybe from an infected source that keeps on getting inflamed over and over again, like in venous ulcers or chronic ulcers or in burns or even chronic discharging sinuses. Okay, now there were a few characteristic features of this ulcer where it arises from a scar or an ulcer. The edge is not always raised or everted. It is not invasive, and it has slow growth. So we have concluded from here that the bone or the muscle is free. Okay, also there are no lymph nodes. Okay, which means that it arises over an area of inflammation. The lymphatics are sort of not like the normal skin. It is maybe a bit destroyed in those regions. This is like over chronic inflammation, the skin is not as healthy as a normal skin. So of course the lymphatic drainage will be less. Of course the penetration of this is less, because the ulcer is not a very invasive ulcer, okay, not a very aggressive or an invasive ulcer, okay. So these are points in favor of a Marjolins ulcer, okay. Now the examiner asks us, are there clinical features in favor of a squamous cell carcinoma? If you keep a Marjolins ulcer for a very long time, it starts to become malignant and it becomes a squamous cell carcinoma. Okay, so we know that this is an ulceroproliferative lesion. It has everted edges. It looks like a floret of a cauliflower. It has bloody discharge, and of course, sometimes when the tip gets necrosed due to loss of blood supply, it starts to give a foul smelling, fishy sort of a discharge. Okay, there's induration at the base, you've seen that. And of course, if there is lymph nodes in certain cases, then of course it goes in favor of squamous cell carcinoma, of course. But sometimes in Marjolins ulcers, of course, we've already discussed that we do not have lymphatic dissemination in these cases, okay. What is the source of malignancy in the squamous cell carcinoma patients? Okay, so the source is the keratinizing cells. The source is the keratinizing cells of the epidermis and the appendages. It arises from stratum basal, okay. It happens due to UV radiations, most commonly causing dimers amongst the keratinocytes. Basically what happens, the UV rays come in, they cause thymine dimers, okay, and they cause these changes within keratinocytes, okay, within the keratinocytes. And of course the most common gene mutated in this is a p53 gene, okay. So then what happens, these tumors express IHC markers like cytokeratin 1 and cytokeratin 10, okay. So the most common area from where it arises is the stratum basal, and of course these are from the keratinocytes or the keratin secreting cells of the epidermis, okay. Now what are the differential diagnosis of these cases? Okay, the differential diagnosis is, of course, it can be actinic or solar keratosis, a basal cell carcinoma, a keratoacanthoma, pyogenic granuloma, and seborrheic warts. Of course, these are for smaller lesions, and when they're quite large, we know it's a diagnosis clinically that it is squamous cell carcinoma. Okay, what are the risk factors of developing squamous cell carcinoma? Of course, exposure to sunlight is the most common reason why you get squamous cell carcinoma. And now, initially, it was said that it was a occupational hazard, but now it is more of a recreational exposure, because there are people with fair skin who go to the beaches and they use tanning beds. And of course, when we are doing these, it is actually a dose dependent relationship of developing these malignancies in the individual, okay. So if you use UVA for psoriasis, the psoralen based treatments, that is also risk factors. If you have a disease process like HIV or a transplant recipient who are chronically immunosuppressed and they have lack of immune surveillance in the body, chronic inflammation, as we have discussed, ionizing radiation, heat and exposure to chemicals, of course heavy alcoholics and tobacco chewers, and of course it can rarely come from basal cell carcinoma. Of course, if you have squamous cell carcinoma of the genital regions and the oropharynx, virus that is most important is human papilloma virus. They can come from warts, and later on they can develop into malignancy, or come from carcinoma in situ, and then they can progress into invasive malignancy, okay. The most common genes involved in human papilloma virus are the E6 and the E7 gene, which affect the retinoblastoma, and the P53 genes due to the infection which with human papilloma virus. Of course, there are vaccines available for these patients, Gardasil and Cervarix, okay, in squamous cell carcinoma of the cervix, okay. So there are also various inheritable disease conditions that can lead rise that can cause these malignancies in patients, okay. So what are the inherited syndromes? Now the inherited syndromes are xeroderma pigmentosum, dystrophic epidermolysis bullosa, and oculocutaneous albinism. So if you forget this, just remember this picture of the boy with multiple dotted, tiny millet-like dotted marks all over the body. That is xeroderma pigmentosum. So this patient landed up with a squamous cell carcinoma of the scalp, and just see the tiny, in this very great picture where we can actually see the tiny dotted lines all around the body due to the mismatch repair excision, base excision mechanism that is deranged in the patients. Okay, so what are the precursor lesions of the squamous cell carcinoma? Okay, so precursor lesions are something which are commonly asked in various entrance examination. It is, if you want a one word answer, it is actinic keratosis, also known as solar keratosis. Okay, it is basically keratinocyte dysplasia, and the thymine dimers that were forming inside the keratinocyte, they, when they become malignant, they give rise to squamous cell carcinoma. But when they are dysplastic, then it is called squamous cell carcinoma in situ, which is called actinic keratosis, which means that they have not crossed the basement membrane. They're above this and they have not crossed the basement membrane. Once they have crossed, it becomes invasive squamous cell carcinoma. Okay, now there are various types of actinic or solar keratosis. It can be a hypertrophic, atrophic, bowanoid, acantholytic, and pigmented. Okay, and the risk of progression is 6 to 10%. Okay, you might not remember all of this data, but of course it is dysplastic and it does not spread to the basement membrane, so it is in a in situ cancer, or rather a dysplastic situation, which is a precursor lesion. And what is the treatment of this? We give the patient topical 5-fluorouracil or imiq mode, inguinal mebutate. You can use things like curettage and photodynamic therapy also to treat these patients. Okay, now if somebody asks us like how will we prevent squamous cell carcinoma, let us talk about prevention. Okay, in these cases we can use sunscreens, okay, which are SPF 15 onwards sun protecting factor. We can use vitamin B3, that is nicotinamide. Okay, we can use also retinoids. Okay, so these are protective factors against squamous cell carcinoma. Okay, now when we go to carcinoma in situ, from actinic keratosis, which was dysplastic, we go to carcinoma in situ, which means it is a malignancy but it has not crossed the basement membrane. Okay, now terminologies like in carcinoma penis, you have something called Bowen's disease and you have something called erythroplasia of Weyrat. Okay, these are reddish colored lesion that appear on the glands and the shaft of the penis. Okay, now there are various terminologies of squamous cell carcinomas in various parts of the globe. Chimney sweeper's disease is something that is squamous cell carcinoma of the scrotum. Okay, Kangri cancer is again people in Leh and Ladakh, they tend to sleep with a bag of hot, rather coal and metallic pot with coal in it, which basically gives them heat. Now that causes squamous cell carcinoma over the abdomen and over the skin of the body. That is called Kangri, because that thing that they use is called a Kangri cancer. Kang cancer is when the people sleep on heated beds, so they get these malignancies over the back and over the legs. And countryman's lip is carcinoma of the lip due to squamous cell carcinoma. We can talk about this more in the head and neck cancer class. Okay, now coming to another entity that is called keratoacanthoma. See, this looks like a dome. This looks like a dome with a little bit of crust in the top. See, this is the crust that you can see. This area is the crust. Okay, so it is a very symmetrical dome shaped lesion with inflamed skin, which is capped with keratin. Okay, which is capped with keratin and debris. Now this grows rapidly and some people call it a self-healing squamous cell carcinoma. So the recommendation of this is surgery. Treat it like a squamous cell carcinoma and take it out. Okay, so then the examiner asks us what are the types of squamous cell carcinoma. So we can have macroscopically an ulcerative type which grows outside, a proliferative site which is rather infiltrative and grows inside, and we have ulceroproliferative which is probably which grows in and out and causes a little bit of more tissue destruction. Okay. What is a varicose carcinoma? A varicose carcinoma is again a low grade carcinoma which grows very slowly and rarely metastasizes. It is deeply invasive to the underlying tissues, so it is difficult to eradicate. It is slow, but it rarely metastasizes. Again, it is very invasive. Okay. After radiation, it becomes more aggressive. So this tumor is called Ackermann's tumor. See, there are a couple of contradicting points in this diagnosis, but this comes very frequently in any MCQ test. So this is called Ackermann's tumor. This is a very commonly asked MCQ that is asked to the students. Okay. So where various sites of developing squamous cell carcinoma. Okay, you can have squamous cell carcinomas of the eyes and orbit. You can have it in the lips. You can have it in the oral cavity, the pharynx, the upper esophagus, the anal canal, the penis, the cervix uteri, the lungs, and of course you can have metaplastic lesions in your ducts of the breast and other places where we have squamous metaplasia, from where we can get this malignancy. Okay, so this is a squamous cell carcinoma of the vulva. Squamous cell carcinoma of the vulva. This is squamous cell carcinoma of the eye into the orbit. This patient will require a orbital exentration surgery, and we can cover it with a muscle of temporalis and cover the eye, and we can put in a graft. And of course, if you believe in putting in prosthetic eyes, you can do that also. Vulva, if it is a small lesion and it is resectable, we can go ahead with surgery, but if it is a larger lesion, we generally prefer to do a definitive CTRT. Carcinoma penis, you need to do a surgery. If it is limited to the distal penis, we can do a distal penectomy with penile preservation, of course. And if it goes deep into the shaft and involves the urethra, then it is prudent to do a total penectomy with a perineal urostomy. Okay. Now, of course, we need to address the nodes of the draining region also. So this is carcinoma penis, and of course this is a patient with leprosy. See, you can see patient with Hansen's disease with destruction of the fingers. Okay, so this patient has Hansen's disease. Okay, now due to this there is neuropathic ulcers, also known as Charcot's joint, which is started to erode and gradually cause chronic inflammation and cause a squamous cell carcinoma that you can beautifully appreciate in this person. So of course for this patient the management would be an amputation. Okay,